Hola, muy buenos días y muy buenas tardes a todos. Estamos en este primer webinar de este año y corresponde en esta ocasión, en esta primera ocasión, a la Dirección de Nutrición, la coordinación del mismo y para eso, pues le cedo la palabra a Liliana Ladino, quien es la directora de nutrición. Adelante, Liliana.
Gracias, Rodrigo. Buenos días para todos. Bienvenidos a este webinar. Realmente estamos muy emocionados de estar aquí porque es un tema que venimos trabajando desde hace muchísimo tiempo y queremos compartir con ustedes sobre todo la más reciente evidencia. Ya Catalina, que es la coordinadora de este webinar de hierro y del Consenso Latinoamericano de Hierro, va a estar coordinando la sesión. Así que, por favor, si tienen preguntas, escríbanlas de una vez durante el transcurso de la presentación. Tenemos un invitado muy, muy especial en alianza con la Sociedad Europea. Así que, sin más preámbulos, Catalina, todo tuyo.
Hola, buenos días para todos. Un placer estar acá con ustedes, muy emocionados por poder compartir este espacio. Hoy nos acompaña el doctor Magnus Domellöf. Él es profesor en pediatría en la Universidad de Umeå en Suecia y es un médico tratante en la unidad de neonatología en el hospital de la misma universidad. El doctor tiene muchos proyectos de investigación en relación con neonatología, nutrición pediátrica y neurodesarrollo y tiene más de 230 publicaciones indexadas. Es miembro ya hace varios años de la ESPIGAN y fue director del Comité de Nutrición de la misma sociedad entre el 2018 y el 2021. Entonces, él nos acompañará hoy con este interesante tema que esperamos nos abra más caminos para entender el funcionamiento de cómo funciona el hierro y en qué momentos realmente debemos administrar hierro a nuestros niños. Welcome, Professor Domellöf.
Muchas gracias. Buenos días para todos. Sorry that extent, that's what the extent of my Spanish, so I will continue in English. And I'm really happy to be invited. I would like to thank the organizers for inviting me, and I would like to thank you guys for tuning in so early in the morning. I will try to share my screen now. So I was asked to talk about with a topic, why not give iron drops to all infants? And so this illustration shows here a baby that receives iron drops and that turns out to be kind of a super iron baby. So is this the case, or are there other factors that we need to consider? So first of all, we know that iron deficiency is the most common nutritional deficiency globally, and it's the most common cause of anemia globally. It causes 25 to 50% of anemia in children, and this map on the right shows the global anemia prevalence in children less than 5 years. And the map is a little older, but the most recent data from 2019 says that 39% of children under 5 years have anemia globally. And you can see, of course, the incidence is very varying between different continents. So we see that in sub-Saharan Africa, we have a very high incidence, 61%, and or prevalence, and 52% in South Asia. In Latin America, it's a bit lower, and also in the European Union and North America. But still, it's a big global problem, and there are large regional differences. And so talking about iron is a very special nutrient, and I would like to give two examples of that. First of all, there is no mechanism for excretion of iron. So if you take in iron in the diet or as a supplement, and then it's absorbed in the intestine, then it's no way for the body to get rid of iron. So that's why you can have iron overload problems. And that's also why the intestinal iron absorption is very tightly regulated. We know quite a lot nowadays about the molecular basis of this iron regulation, and we know that this molecule, hepcidin, can you see my pointer here? Hepcidin is a very important player here. I will come back to hepcidin. And we know that when you have high iron stores, or when you have an ongoing inflammation, for example, you will block iron absorption thanks to hepcidin. Also, the second fact why iron is very special is that healthy, normal birth weight infants need almost no dietary iron during the first 6 months of life, and that's pretty unique among nutrients. And why is that? Well, it's because we have a very active placental transport of iron from the mother to the fetus during late pregnancy, and then we have at birth quite a high hemoglobin level here, around 170 grams per liter on average, which falls very rapidly during the first weeks of life to about 120, and the iron is transferred from the hemoglobin to the iron stores. So the baby is born with some iron stores, and then it increases. So actually the baby has enough iron to cover the first 6 months of life. I will show a slide here showing the same thing. Here at birth, we have hemoglobin in red here. This is the total body iron. So we have iron in hemoglobin, and we also have some stores at birth. And then during the first weeks of life, hemoglobin level drops and iron is transferred to the stores. So then it takes up to 5 or 6 months of life until you have depleted these iron stores. But after that, theoretically, the baby has, or the child has very high iron requirements. So that's after between 6 and 24 months, we have a challenge with high iron requirements. So if we go back to the situation during the first 6 months of life, we know that breast milk has a low iron content. So the baby has very low iron needs, and the breast milk has a low iron content, which is actually an advantage because it prevents infections. It's known that iron is essential for almost all pathogens. So we have developed ways to prevent infection by depriving iron from the bacteria. So first, in breast milk, we think it's an advantage that it's low in iron, and also when you get an inflammation in the body, it will induce hepcidin production in the liver, and it will block uptake of iron from enterocytes, and it will block iron transfer from reticular endothelial cells. So we will have an extremely low concentration of iron in blood or in plasma in a stage of inflammation, which is good for prevention of sepsis, really. So iron is very connected to immune defense. But as I mentioned, at 5 to 6 months of age, the neonatal iron stores are depleted, and then you have high iron requirements, and you need iron-rich foods. And so what we see, the risk of iron deficiency anemia in high-income countries typically increases. So it's between 1 year and 2 years, really, that you have, or up to 3 years, that you have the highest risk. In countries with a higher prevalence of anemia, or in low-income countries with a high prevalence of anemia among children, this extends up to 5 years. Now we have an example of 2 siblings. Here is the big brother, who is 2 years old, has a normal hemoglobin value of 120 and a normal ferritin of 37. And here is the little sister, who is 8 months old and has a hemoglobin of 44 and the ferritin of less than 6. In this case, it turned out that the reason for this baby having a severe anemia was that she is a Swedish baby, and she had consumed only standard cow's milk for the most of her first 8 months, which is not iron fortified. So she developed a severe nutritional iron deficiency. So, but she looks quite healthy. She has been growing normally, and she's a little pale, as you can see, but otherwise she seems to be very normal. So why are we really worried about this iron deficiency? Well, it's typically because we are really we are worried about the brain development of children who develop severe iron deficiency. We know that iron is essential for many aspects of brain development, for example, myelin formation, monoamine synthesis and function, neuronal and glial energy metabolism, as well as neuronal growth and arborization. And it has been shown in very nice studies from the 1980s and onwards, and not least studies in Latin America, that iron deficiency anemia in infants and toddlers is associated with a poorer cognitive development, cognitive impairment, motor impairment, and behavioral problems, and also mental problems later on, such as anxiety and depression. So we can see here one of these studies. They have infants and toddlers, and this is the mental development index, and you can see these are toddlers who are non-anemic, and you see those that are anemic, those that have an iron deficiency anemia, they have really much lower mental development index. So this has been shown in observational studies. Of course, these studies have the disadvantage that these babies that have a severe or iron deficiency anemia, they might also have other risk factors, right? And it has been shown that despite treatment, even if you give iron to these babies and the hemoglobin normalizes, these children have long-lasting problems persisting at least up to adolescence. So really, we would like to prevent this. And what are the results of giving iron supplements, such as iron drops? Well, there have been a lot of studies, and there have been slightly conflicting results. A meta-analysis, I've been just presenting here the latest meta-analysis, and one from 2020 included 5 studies of iron supplementation in low and middle income countries, and showed significantly higher scores for motor and mental development after in the supplemented groups. It's not a huge effect size, it's 0.28 and 0.14 standard deviations respectively. But it was a significant effect. Also, a meta-analysis from 2019 included 23 studies of iron or multi-micronutrient supplementation and showed a significant positive effect of iron supplementation on motor development, with also quite a small effect size. However, a recent randomized controlled trial in Bangladesh, which is, I think, the largest, one of the largest studies of its type, it randomized babies to iron, multiple micronutrients, or placebo from 8 to 11 months. So it was quite a short period. It was only 3 months intervention, but it showed no significant effect on Bailey scores. It should be noted that 45% of those infants in Bangladesh had anemia at baseline. So overall, I think that these studies suggest that there is a positive effect of iron supplementation in populations at risk, especially if anemia has not yet developed. There is a discussion that when you have developed iron deficiency anemia, maybe you will have irreversible effects on neurodevelopment. So probably it's good to go in and be preventive measures rather than therapeutic measures. However, we have to identify these populations at risk. And one population at risk are babies with a low birth weight. And we performed a study in marginally low birth weight infants with a birth weight between 2,000 and 2,500 grams. And this is quite a large group of newborns. It's between 3 and 5% in Europe and the Western world, and it's up to 15% in South Asia of all newborns. It's kind of a forgotten group. They are perceived as healthy. They don't need much neonatal care, and they are often excluded from studies, and they were excluded from these meta-analyses, for example, that I mentioned previously. But we know that these babies have increased risk of later behavioral problems, neuropsychiatric problems, school problems, etc. And theoretically, they do have a risk of iron deficiency, because if we go back to this chart about the total iron in body, we can see that these babies who have a low birth weight, they deplete their iron stores much more rapidly. So they will need extra iron well before 6 months of life, during the period when they are typically still breastfed. So we did a randomized controlled trial of iron supplements in 285 otherwise healthy infants with a birth weight between 2,000 and 2,500 grams. So about 50% of these were term babies, and the rest were slightly preterm, and the term babies were obviously then small for gestational age. So the intervention was iron drops, not 0, meaning placebo, or 1 or 2 milligram per kilogram per day. And so they were randomized, and they received the intervention from 6 weeks, starting at 6 weeks of life and ongoing until 6 months of life. And we showed very clear effects on iron deficiency and iron deficiency anemia. It was quite common in the placebo group, but as you can see, it was in principle eradicated when giving 2 milligrams per kilogram per day of iron. So we had a good effect on iron status, but what about the health outcomes? Because that's really what we are after. We want to have good health outcomes. So interestingly, when we followed up these infants at 3 years of age, we did not see a difference in cognitive development, but we did see a very clear effect on behavioral problems. Here, using the Achenbach Child Behavior Checklist, we see that the babies in the placebo group had significantly higher. They had about 13% behavioral problems, and it was only like 3% in the 2 iron groups, and also in a control group of babies with normal birth weight. So this was the follow-up at 3 years, showing that iron supplements significantly reduced behavioral problems. And we followed up these children at 7 years, and we saw a remaining effect. You can see exactly the same pattern here. And it was especially in externalizing behavior that we saw this effect. So we come back to the original question, that why not give iron drops to all infants? It should be solved this problem then. Well, we know, so the benefits would be prevention of iron deficiency, prevention of anemia, and improved neurodevelopment, as I have been showing you here. However, we have to remember that we don't have a mechanism for iron excretion. So there is always a risk of iron overload, and it's a very important, and we know that iron supplements can have harms in children, in young children and infants. There are studies showing that unnecessary iron supplements can give adverse effects such as poor growth, poor neurodevelopment, increased risk of infections, diarrhea, and disturbed gut flora. So probably the most alarming of those is the increased risk of infections and the poor neurodevelopment. And I will come back to this. There's one paper actually also from South America, from Chile. This is quite an old study. It was also by Betsy Lotzoff group. 6-month-old non-anemic infants in Chile. 800 of them were randomized to receive from 6 to 12 months either an high iron formula with 12.7 milligrams per liter, which is higher than the usual follow-on formulas, or a low iron formula, 2.3 milligram per liter. And the results here was that and these were non-anemic infants, so they were screened before, and the anemic ones were excluded. And then they actually found no difference in iron deficiency and anemia at 12 months. It was around 3-4% with no difference between groups. So this shows that this was really not a high-risk group for iron deficiency anemia. Even the low iron babies had a quite low risk of iron deficiency anemia. And then, interestingly, at the 10-year follow-up, they found that the high iron group had significantly poorer neurodevelopment in several areas. It was significant for spatial memory and visual motor integration. And as you can see from these graphs, for all of these measurements, for the IQ, general IQ, and for spatial memory, visual perception, etc., we see the same tendency, that the detrimental effect of iron is more evident in those with a higher baseline hemoglobin level at 6 months, suggesting that those with a good iron status to begin with, they did not have a positive effect, but rather a negative effect of iron. So we can conclude that compared with other nutrients, iron has a relatively narrow safety margin. There's a risk of iron deficiency if you give too little iron, but there's a risk of iron overload and adverse effects if you give too much, especially if you give it to iron replete infants. So this is another study showing the change, because the risk of infections have been shown also in serum. The risk of diarrhea has been shown in numerous trials. So you can wonder, what is the reason? Well, there's this interesting paper from Kenya from 2015 showing that iron, if you give a porridge with a high iron content as compared with placebo, you will find an increase in firmicutes, Escherichia, Shigella, Clostridium, and a decrease in bifidobacterium. So you can see clear changes in the fecal microbiota, and we showed some similar results in randomized control trial published here in 2019. 72 healthy 6-month-old receiving iron drops, high iron formula, low iron formula, and actually we saw the most clear effect we saw in the iron drops group, with less lactobacillus and streptococcus and more Clostridium and Bacteroides. So clearly iron drops has some detrimental effects on the microbiome. And then, as you might know, this is a very famous study from Tanzania, a randomized controlled trial that was terminated before the end of the study, because it was terminated in 2003. And this was performed in an area with a high malaria prevalence. These were children between 1 and 35 months of age. It was a huge study. It was 24,000 infants or and young children. And they were randomized to get iron and plus folic acid, and with or without zinc, or not iron. And the iron groups had, alarmingly here, 15% increased mortality and 11% increased hospital admissions. And in a sub-study, they saw that the risk for serious adverse events was higher in those that were initially iron replete. So it's the same really finding as in the Chile study that I mentioned previously, that if you are iron replete to begin with, the iron supplements here increased the risk of severe infections in an area with a high malaria prevalence. So are there other methods except for iron supplementation that you can use to improve iron status? Well, certainly there are, and this is one of them, delayed umbilical cord clamping. It's very well known that if you wait some time, this is the number of seconds that you wait until you clamp the cord, you will get an increase in infant blood volume. And actually, if you wait for a couple of minutes, you will increase the blood volume in the baby by more than 30%. We performed a randomized controlled trial in 400 low-risk pregnancies, and the intervention was clamping before 10 seconds, which was early clamping, or delayed clamping after 3 minutes. And the delayed cord clamping group, they had actually a significantly higher birth weight. And first we thought it was kind of a mistake in the, or that we were unlucky in the randomization, but it turned out that this was, the birth weight is measured after the intervention. So this reflects that there is about 100 milliliters more blood in these babies. That's the result, that they get a slightly higher birth weight, which was significant. They also had a higher hemoglobin on day 2. There was no difference in neonatal jaundice, postpartum bleeding, or umbilical artery blood gases. And then when we looked at them at 4 months, we saw differences in iron status, which is not very unexpected, but this was a Swedish population, so the risk of iron deficiency was quite low. And then interestingly, when we followed these children up to 4 years, we saw a significant effect on fine motor function, which was measured in 3 different ways. It was measured by the WIPC, processing speed, the movement ABC, drawing trail, and the ASQ, fine motor scale. And as you can see here, it was significant all over in the total population, but it was much more significant in boys than in girls. So, to conclude here, the recommended management of healthy infants with normal birth weight for the first 6 months of life is that you have delayed cord clamping, you breastfeeding, which is good for a number of reasons. And if breastfeeding is not possible, you should give an iron-fortified infant formula. And then if you have a low birth weight, you should give iron supplements. And after 6 months and up to 3 years, you should remember to give an iron-rich diet, including meat or other, also some other foods, lentils and so on, that contain high iron concentrations. And also you should use iron-fortified foods like iron-fortified cereals, etc. And importantly, you should avoid cow's milk as a drink before 12 months of age. If the babies drink, as the example I gave you on a baby that had been drinking just regular cow's milk, it's a very high risk that these babies develop a severe iron deficiency anemia. So you should avoid it before 12 months, and you should limit the intake of cow's milk up to 3 years to less than 500 milliliters per day. And this you can find in the ESPGAN guidelines that we have been writing. And then there is a discussion about should you give iron supplements in those infants that are breastfed or mainly breastfed after 4 months of life. This is recommended in the US, but it's not generally recommended in Europe. It's said in our guidelines that it should be given only in populations with a high prevalence of iron deficiency anemia. And we actually recently did a study to compare the European and the US guidelines. It was a blinded randomized control trial in Sweden and Poland, 220 healthy term infants who were predominantly breastfed at 4 months. They received meaning that they received more than 50% of feeds breast milk. The exclusion criteria were low birth weight and anemia at inclusion. The intervention was iron 1 milligram per kilogram per day or placebo from 4 to 9 months of life. And the primary outcome was psychomotor development at 12 months using the Bailey scale. And the secondary outcome was the other scales at 12 and up to 36 months and iron status, etc. And we haven't published these results. They are accepted for publication in JAMA Pediatrics, so they will come out soon, but they are in press. But I can tell you that the preliminary results support the European approach, meaning that we did not see an advantage of giving iron supplements to these babies who are predominantly breastfed between 4 and 9 months of life. So to conclude, I would like to cite a bit from a very nice book that is called Nutritional Anemia by Springer, that we have been writing a chapter in that book. And it says that in all populations, we should encourage delayed cord clamping. Formula-fed infants should receive iron-fortified formula, and of course with other micronutrients as well that can cause nutritional anemia, such as B12. Low birth weight infants should receive iron supplements, which you mentioned, and we should encourage iron-rich diet for infants and toddlers up to between 6 and 36 months of age, and avoid high intakes of unfortified cow's milk. And also in the older children, you should screen adolescent girls for iron deficiency, and if needed, they should be iron supplemented. In populations with a high prevalence of anemia, I think it's important to consider that only 25 to 50% of anemia is caused by iron deficiency, and the reasons for anemia can be very different in different populations. So I suggest in this case that you have a region or a population with a high prevalence of anemia, you should gather local baseline data on the most common causes of anemia in different age groups, as well as the prevalence of infections and inflammations to guide the intervention programs. And you should check iron deficiency anemia, and it requires, of course, the combination of iron deficiency, for example, a low ferritin value in combination with a low hemoglobin value. And you should consider other causes of anemia, such as other nutrient deficiencies, vitamin B12, folate, vitamin A, infectious diseases, for example, malaria, diarrhea, respiratory tract infections, and genetic causes, for example, thalassemia and sickle cell disease, which we know are differently prevalent in different populations. And if you have a population with a high prevalence of iron deficiency anemia, for example, more than 10% of infants and young children having iron deficiency anemia, then of course you should do some sort of intervention, and this intervention should be sustainable and cost effective. And we have seen very nice examples also from South America, for example, the study in Colombia by Olaya and co-workers, giving community intervention, encouraging the use of chicken liver, which was a cheap and readily available source of iron in that population, which can be efficient. Other alternatives, of course, are then iron supplementation, for example, iron drops for all infants in this specific region that you have a high prevalence of iron deficiency anemia. And you should also consider multi-nutrient supplements if other deficiencies are common. And then, of course, you should do a follow-up of the effect of this intervention. And if inflammation is common, public health measures should be taken to prevent and treat malaria, HIV, helminthic infections, as well as respiratory and gastrointestinal infections, especially in children under 3 to 5 years of age. And malaria prevention and treatment is especially important if iron supplementation is given. It has been shown after this Tanzania trial that I told you about. It has been shown in numerous trials that if you combine iron supplementation with malaria prevention and treatment strategies, then it can be safe to use iron supplements in those populations. Also, you should have locally adapted anemia prevention programs that include training of healthcare workers, dietary counseling, and community participation. So in conclusion, iron deficiency is a major global health problem in children. It's important to prevent, to optimize neurodevelopment. However, you should also avoid excessive iron intakes. Delayed cord clamping is an extremely cost efficient and easy and effective method to decrease iron deficiency anemia in the population. Dietary advice is also suggested, adequate nutrition products, and iron supplements, but they should be reserved to high-risk groups, for example, low birth for infants or regions and communities with a high prevalence of iron deficiency anemia. And finally, this is, as you notice, a very active research area, so there's new studies coming up all the time. So thank you very much for your attention, and I would like to thank all my co-workers in this field. Thank you.
Thank you
I
very
will
much,
be happy
Professor.
to take questions.
Yes, we have some questions. Thank you very much, Professor Domellöf. It was a wonderful conference. We have some questions. The first is, how to argue against giving cow's milk to children under 2 years of age, taking into account the WHO recommendation of October 2023?
Our recommendation is that you should not give cow's milk as a drink to I know that there were some new recommendations coming out 2023 that kind of we were actually quite critical to those new recommendations, because they say that you could give infant formula or you could just as well give regular cow's milk. I think if you read the background to those recommendations, they say the same thing as I said, that there is a risk of iron deficiency if you go that way. But kind of I don't know why they ignored that risk in the final recommendation. You have to ask them. I think it's yeah, I don't agree with that recommendation.
Okay, perfect. We have another question. Which should be the definition of the top of the daily intake of iron for infants?
Excuse me?
Because
Can you repeat?
Sí. Sorry. Wait. Let me.
What was the highest recommended intake?
Yes.
Yeah.
The top of the dietary intake of the iron for infants every day.
Yeah, I think if you can achieve around 1 milligram per kilogram after 6 months of life, that's a very good level. You don't have to exceed that really. If you give iron supplements, we usually say between 1 and 2 milligrams per kilogram. So that's kind of the top. You should not, if you give more, then it's more like if you're treating iron deficiency anemia, then you can give higher doses for a shorter time.
Okay. We have another question. What laboratory test should we request from infants to justify giving iron?
Yes, if you should screen an infant, yeah, the minimum I would suggest is to check the hemoglobin and the ferritin. If you have an ongoing inflammation, of course, the ferritin might be falsely elevated, so it could be good also to check like C-reactive protein or some other measure of inflammation to make sure that you don't have that as well. Otherwise, hemoglobin and ferritin is a very good combination.
Okay. We have another question from Carlos Cuervo.
And also, you have to remember,
Yes.
that the normal values for hemoglobin and ferritin are very different in different age groups. During the first year of life, the normal reference levels change quite a lot. So you have to make sure that you have appropriate references for the age of the infant or child.
Okay. The other question is, would immunosuppressed babies and cystic fibrosis disease babies have limitation in iron supplementation?
I'm not really aware of course, they will have some malabsorption, fat malabsorption ongoing. I'm not sure if they would have also poor iron absorption. I'm not really aware that iron deficiency is a big problem in that group. I would check if you're worried about those patients, you should screen them, as I suggested, using hemoglobin and some marker of iron status.
Okay, thank you very much. It is recommended to administer probiotics, prebiotics, or symbiotics to children receiving iron supplements?
No, well, we know that some infants and children and also adults, of course, if you give iron supplements, you will have some changes in the color and the consistency of the feces. And as I showed, you will have some changes in the gut microbiota. So if you have gastrointestinal problems, I think you could consider that, but we wouldn't normally give it. When we did our blinded randomized study, for example, in infants, we got exactly the same number of gastrointestinal events reported in the iron groups as in the placebo group. So I think in infants, you can't really say that they have a lot of gastrointestinal problems from the iron drops.
Okay. Let me check chat. We have two more questions to answer yes or no, because people could have lost some information. We want to emphasize these specific questions. The first is, do you advise against systematic and general supplementation in infants with iron drops?
Yes, if you should give like a general recommendations that all infants in Latin America should receive iron drops, I should definitely say that's not a good idea. I think you should identify subpopulations, maybe some countries or some parts of some countries, or maybe some communities or some risk groups where you have a big problem with iron deficiency, and to those babies you could give iron supplements. I don't think you should give a general supplementation to everyone, because as I showed, there are numerous risks with that. You can increase the risk of infections, diarrhea, and you can, in some studies it have been suggested impaired growth, and you can also even get poor neurodevelopment, meaning exactly the opposite of what you're trying to achieve.
Okay, thank you very much. The other question is, what type of iron should we give to infants?
I think there are different iron salts and other iron preparations. I don't think it makes a big difference which type you use, really. I think you should use any iron. Of course, you shouldn't give metallic iron or something like that. I mean, there are these products, but if you have an iron salt of some sort, it doesn't really, even if they have slightly different absorption in these one-dose experiments, I think if you give them over time, the baby will adapt and absorb what they need from it. If you don't give too much, then they might absorb too much.
Okay, we have another question here. What do you think about the recommendation of supplementation of iron in children with autism and trouble sleeping?
Well, I think you should check these babies for iron deficiency, and if they have iron deficiency, they might benefit from iron supplementation. I'm aware of some studies that they have suggested that iron might be effective in those conditions, but I would check the baby first, or the child rather, because these are children.
Okay. We have a question from Brazil. In Brazil, there is a high incidence of anemia in pregnant women, especially in the third trimester of pregnancy. Would you recommend iron supplementation for this baby from 3 months of age?
Yeah, when it comes to pregnant women, we know that the hemoglobin level drops quite a lot, especially in the middle of pregnancy, mid-pregnancy. And I think, first of all, before you know if these women have iron deficiency anemia, you need to check both hemoglobin and ferritin and see, do they have an iron deficiency anemia, or is it just an anemia due to the extra fluid that they accumulate during mid-pregnancy, or is it a real iron deficiency anemia? If the mothers have iron deficiency anemia, they should be treated, of course. If there is very little data, actually, most studies don't show any effect of iron supplementation of the mother on the iron status of the baby. So I think even if you might think it would have an effect, if you look at the meta-analysis, there is no significant effect of iron supplementation during pregnancy. If you give multi-nutrient supplementation to high-risk mothers, you might improve the birth weight of the babies, which indirectly, of course, will improve their iron status. So that might be a good thing. If you have a mother with a severe iron deficiency anemia, like a hemoglobin less than, 60 grams per liter, and very low ferritin levels and so on, that mother, of course, in that case, even the baby might get iron, the fetus might get iron deficient, but that's quite rare, I would say, even in countries with a high anemia prevalence. I would say this is quite rare. So you have to check what is the actual status. And the reason for this is that the placenta actually prioritizes the fetus before the mother. So if you have a situation with an iron deficiency in the mother, the placenta will make sure that the baby gets enough, even if the mother has an iron deficiency. So it's quite a robust protection for the fetus.
Okay, we have the one last more question because we are on time. If we have to use iron, we should use also folic acid.
Yes, it's a very common combination to give iron and folic acid, and it depends on if you have folic acid deficiency in your population. I think it's a good idea to combine. If you don't, so that's what I mean. You should check the situation in your. You could make a small study in your population and see, do the children have iron deficiency? Do they have folic acid deficiency? Do they have B12 deficiency? Do they have some other vitamin A or some other nutritional deficiencies? And then you could have a program with a combined supplementation. And that's it's a quite common combination.
Okay, thank you very much, Professor Domellöf. I'm going to give Liliana Ladino for the last comment.
Thank you, Professor. We have reached almost 200 people connected in time. It is really, really impressive. Thank you. Thanks indeed. I just want to close, remark some important topics just to clarify, and I will read a comment from a participant in Spanish and that to translate in English just to be aware with this information. Doctor Vera el doctor Vera dice, en un país con 40% de malnutrición de embarazadas, alta prevalencia de anemia, poca lactancia y zonas de malarias, recomendaría suplementar con hierro 1 miligramo kilo día en niños a término. This is referring to supplement in all of the majority of our countries in LATAM, that it is reach a high amount, a high prevalence of anemia in not just in children, but also in pregnant women. And we have a low rates of breastfed children also. And he insists, this doctor insists to recommend the supplementation with iron without lab, just for default in term infants, healthy and term infants. What do you think about this? And just to clarify that when you recommend and referring to the paper that was published from Colombia, offer iron-rich food as complementary food, for instance, liver chicken or meat, first, and after that to offer fortified complementary food, as mean as the infant formula could be that, or cereal infant for babies. And after that to offer the supplementation. That will be like a, I don't know, like a step by step, or you can offer together. What is your recommendation considering our situation in our countries?
Yes, so that's a great question. And I think that you have, as I mentioned, you have to look at the prevalence of iron deficiency anemia, and not just anemia, but iron deficiency anemia in your population of young children. And then if you have a high prevalence, I fully agree that you should first, I think the easiest way to go is the delayed umbilical cord clamping. And I think that you have something, I don't think you have implemented that in most of Latin America. So I think you should talk to your colleagues in the obstetric department and explain to them how important it is with the delayed cord clamping. I think that's one very, very easy step. And then the next one could be, as you suggest, to look to try to implement improved iron intakes in the food after 6 months of life, such as iron-rich complementary foods. That's great. And if that's not possible, I think the next step would be then to recommend iron supplementation.
Okay, and about the cow's milk, considering that you and all the organization around the world recommends to breastfeed until 2 years, at least until 2 years, if you need to offer milk that should be an infant formula and up to 2 years? O
We
young child.
suggest infant formula up to 1 year, and then we
Okay.
suggest
So,
after 1 year we suggest not to avoid cow's milk completely, but to limit the amount of cow's milk to maximum 500 milliliters per day.
okay, and you can consider also the young child formula for this.
Yes, we can consider the young child formula, but we have also written a paper about that from the ESPGAN Nutrition Committee, and we say that we have not yet seen really great evidence that I mean, the problem with young child formula is that it's more expensive than regular milk. So I think maybe it depends on the situation you have in your country. But we were afraid, at least from a European perspective, that the families that would have young children at risk of iron deficiency, anemia, they would not choose this product because it's more expensive. So I think that you would probably reach the wrong families with that product, and we are not really convinced that it's we know infant iron fortified formula, that's not controversial, I think, in our group at least. However, the young child formula, I think you have to look at the situation in your country if you should recommend it or not.
Yes, but regarding the economical situation, the young child formula should be the first one.
First one compared to
Cow's milk.
Compared to it depends on if you have a problem with iron deficiency anemia in your population, then it could be a part of the strategy with an iron rich diet. I agree with that.
Perfect. Okay, that's all. We have a lot of questions more, but we will try to answer inside of the last vegan group. Thank you very much for this presentation, for your time, for joining us, and see you next week.
Okay, see you next week in Lisbon.
Bye, bye.
Thank you very much.
Bye, bye. Gracias a todos por conectarse. Chao. El webinar va a quedar grabado dentro de la página del Aspigan para los miembros del Aspigan. Por si ustedes quieren repetirlo, mirarlo, tomar notas. En las redes sociales del Aspigan vamos a dejar un link de un libro que el doctor nos ha recomendado porque tiene un capítulo que escribió sobre este tema. El libro fue publicado el año pasado, entonces se los vamos a dejar por si alguien está interesado en el tema y trataremos de dar respuesta a las preguntas que nos quedaron pendientes a lo largo de la siguiente semana por medio de las redes sociales de Nutrilaspigan. Estamos en Instagram como Nutrilaspigan. Por ahí vamos a tratar de dar respuesta a todas. Cata, no sé si algo más de información.
No, pues muchas gracias de verdad por la gran acogida que tuvo este escenario. Sabemos que es una hora para nosotros bastante compleja por tema laboral. Esperamos que la información haya sido de utilidad y de verdad que esperamos con eso también aclarar nuestro camino hacia el consenso latinoamericano de hierro, donde claramente tenemos que cambiar algunas de nuestras prácticas y poder incidir en las políticas públicas de estar dando hierro a diestra y siniestra sin muchas veces necesitarlo, porque sabemos que también hay riesgos.
Super, Cata, mil gracias a todos por conectarse.
Gracias.
Bonito día, bye. Gracias, Carlos, por todo tu apoyo. Rodrigo, buen día.